Welcome, everyone. I'm Francine Allen, and I'm joined by my colleague, Amy Henriksen. We are registered dietitians and medical affairs managers at Nestle Health Science. We will be moderating today's presentation, a panel discussion, how clinicians use food-based tube feeding formulas. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily present Nestle's views. The material is accurate as of the date it was presented. It is for educational purposes only and not intended as a substitute for medical advice. I'm very pleased to present today's panel. Gerard Miner is a physician assistant in the pediatric GI division of Kidz Medical in Coral Gables, Florida. Tiffany Oster is a registered dietitian, clinical dietitian, and previous supervisor at Providence Health and Services in Portland, Oregon. And Miriam Shimbayati is a physician, a pediatric gastroenterologist at Integris Baptist Medical Center in Oklahoma City, Oklahoma. Because we have a panel of clinicians today for this webinar, each will present more specific information on their background and expertise in their individual sections. So we'll start with Tiffany Oster, who will provide an overview of Blenderized tube feeding formulas. Welcome, Tiffany.
Thank you, Francine. As we overview food-based tube feeding, I think it's become very apparent that there is a growing customer demand for both adult and pediatric populations, in part due to patients wanting to receive formulas with real food ingredients. We do have a growing base of evidence showing that real food-based tube feeding formulas can help improve GI tolerance as well as other benefits, and we will be reviewing some of those today as well. One thing that is important to note is that more research is needed in this area, especially in adult populations. When we're talking about blenderized tube feeding, there are two different options. One is home blenderized and the other is commercially available blenderized formulas. Home blended formulas are great in that they are able to provide the same foods that families are eating in their meals and can be easily modified to meet individuals' needs and preferences. One of the drawbacks to home blended formulas is that they are quite labor intensive and they do require close oversight from healthcare professionals to ensure proper preparation, storage, administration, and proper nutrient adequacy. Commercially blenderized formulas have the benefit of being nutritionally consistent. They're very easy to use and are shelf stable. They do come with a lower risk of contamination, tube clogging, and the risk of inadequate nutrition. And one of the other benefits is that they are much more likely to be available in acute care or hospital settings. As I mentioned, there is growing evidence of the benefits of blenderized products. As you can see here, there are quite a few studies that have been published most recently. Please do note that many of these studies have been done in pediatric populations. And another thing that is notable is that many of these studies are utilizing home blended products as opposed to the commercially available product. So there definitely is room for more research to be done in these areas. With the studies that have been published, we are seeing improved outcomes associated with blenderized tube feeding, and some of those outcomes include improved gastrointestinal tolerance, increased oral intake for those individuals who are able to consume oral foods, increased patient and caregiver satisfaction with the feeding product, decreased gagging and retching and vomiting, an improvement in reflux symptoms, an increased diversity of gut microbiota, decreased healthcare utilization, and many psychosocial benefits. Some of the clinical indicators for utilizing food-based formulas include intolerance to standard formulas, specifically reflux, retching, vomiting, chronic diarrhea or constipation, food issues associated with developmental disabilities, conditions such as neurologic impairment or cancer. It is important to note that oncology is an area that does need some additional research. Other benefits or clinical indications are for severe or multiple food allergies, long-term tube-fed patients who prefer formulas with real foods, and patients who require a thicker consistency to improve their volume tolerance.
Hello, good morning. I'm Gerard Miner. I'm a PA here in South Florida. I've been practicing in pediatric GI about 20 years. I started with the Children's Center for Gastroenterology and Nutrition, and then about 8 years ago, that GI group we merged with Kidz Medical, which is a multi-specialty pediatric group, and we service their GI division. And they cover most of South Florida up into the northern part of the state. We also go west as far as Naples. We have privileges at Plantation General Hospital and most recently Broward General Hospital. So for those of you that know South Florida, we pretty much have every corner of Broward County monopolized now with our GI service. We also provide service to our 2 pediatric total care nursing homes, and I go to each one of those once a month to help with their feeding issues there. A dietitian meets me and we service that community once a month. So Kidz Medical Group headquarters is in Coral Gables. Again, like I said, we cover most of South Florida. We're affiliated with 16 different hospitals. I only work for the pediatric GI group, and we are in the Hollywood region and Broward County. At the very bottom, you'll see in the right corner, it says dietitian coming soon. After many years of begging, pleading, we are finally able to get an outpatient dietitian. So for me, on an inpatient basis, we're rounding in the hospital. We have dietitians that help us on each of the floors. We actually have a dietitian for each specialty. For example, we have a transplant dietitian, we have a med-surg dietitian. So as we move throughout the hospital, we have a large group that can help us out. The problem is our patients go home, and we've had a hard time with outpatient dietary management and consults. So we finally got approval, and we are hiring a full-time outpatient dietitian for our group. We do have to share with endocrine, but I can live with that for now. Initially, we're hoping this dietitian will come on board as we start our new pediatric liver disease and pediatric IBD center. Our dietitian is vital to that, and that was the first position we needed to fill before we can move forward with having our clinic established. So we see a multitude of patients starting at birth up till about 21 years old for our patients without delays, and we can go up to 24 for our patients that do have delays. Most of the patients that I do see in our practice do have some type of chronic illness or feeding disorder. I also manage all of our home parental nutrition and short bowel babies and the non-alcoholic fatty liver disease. Again, we're establishing a clinic, but we also follow those patients. As you would know, all of them have a high need for a dietitian, as well as close monitoring and making sure that their nutritional needs are met every day. The case study that I would like to present to you today is for a little boy. We will call him Leo for the purpose of this presentation. I met him at approximately 3 months of age. He was a twin gestation baby born at 1 kilogram. He was born with a juvenile atresia, and he was left after his surgery with 28 centimeters of small bowel. He did have an intact ileocecal valve, and he had his microcolon was present. When I met him, he was completely dependent on total parental nutrition as well as lipids. When he got discharged from the hospital, the first visit you see there is 5 months. That's his first outpatient visit. He still remained on quite a number of hours of TPN every day. He was on amino acid-based infant formula, but was only tolerating about 7 cc's per hour, having about 4 to 6 stools per day, which is acceptable. Patient continued to be followed. We usually follow these patients every 2 to 4 weeks as an outpatient, even though you see the gaps here. But at 14 months of age, we were able to liberate him from his TPN. We were kind of forced in a way because he had multiple central line infections and we had some access issues. So we tried to just discontinue the TPN at 14 months and see how well he could do. And he did well for a while as far as maintaining his electrolytes and maintaining his weight, but just did not gain weight. And as you'll see, at 16 months, barely any weight gain and no linear growth as well. We did try some other things. We added in some modulars, protein supplements, those types of things. He still did not get up in his weight. He's managed his stools, he managed his electrolytes, but we were just unable to get the patient weight to go up. So then we started having a discussion with the parents about actually resuming TPN, putting a central line in to see if we could help this patient start to get his weight back up. The parents wanted to know if there were any other options or something else we could try. So then at 2.5 years old, we decided let's try a commercially blended formula and see how well the patient would do in hopes to not have to put him back on TPN. So that worked. We started him out with 3 pouches per day. He tolerated it well. The good news is that his stool frequency did not go up, switching him from an amino acid-based formula to this organic blended formula. And he maintains electrolytes, and we're actually able to discontinue the question and loperamide, which are drugs used to help reduce stool frequency. So he maintained his stool frequency without those medications and was changing it to the formula. So fast forward, he got to 5 years old. He still eats by mouth, but also we supplement him still with these pouches per day. He was still doing 3. He would do them overnight, and they would make them his snacks in the middle of his meals per day. His weight started to go up. His linear growth started to increase a little bit, and he's doing well. Before this presentation, I reached out to mom yesterday to see what his current weight is, which is 31 pounds. He still resides on the 1 percentile line, but it's his line that he's maintained since birth, and he's doing really well, and developmentally he's doing well. He still has mushy stools, and he's on no medication. We never had to go back to TPN, so he is tolerating the formula very well, and his growth continues to go forward. Are there any questions?
Thank you so much, Gerard, for that great presentation. We did have some questions that were submitted prior to the presentation. We're going to save most of those to the end, just in the interest of giving each speaker enough time. But I did want to direct one of those questions towards you right now, and that is there increased gas production with the use of a formula that contains pea protein?
No, not in our experience. We have not had that report from parents. The formula is well tolerated. We haven't had any questions about increased stooling, increased gas, increased bloating. So no, the formula is very well tolerated.
Great, thank you.
Hi everyone, I'm Tiffany Oster. I'm a registered dietitian and a certified nutrition support clinician. I reside in Portland, Oregon. My educational background is in exercise science and nutrition, and I have recently started pursuing a master's of business administration and health services. In my professional career, I began as a dietitian in a community hospital, and I was responsible for several units, including telemetry, surgery, women's and children's, and a general medical floor. After a few years there, I transitioned into a role as the primary clinical dietitian at Providence, where I was actually doing home enteral and consulting with our infusion pharmacy for home parenteral nutrition. I did become a supervisor there, and that role concluded in May when I began going back to school full-time. At Providence, as I mentioned, I was the primary clinical dietitian for over 200 enteral patients. I spent a lot of time collaborating with providers in different locations for selecting and adjusting enteral regimens. We did have the opportunity to use a full range of commercially available formulas, everything from standard formulas, peptide-based, elemental, disease-specific, and Blenderized commercially available formulas. In our population, we found the most common challenges were volume intolerance, GI symptoms, including reflux or upset stomach, diarrhea or constipation, phlegm, and weight maintenance. When making initial formula choices for patients, we typically began all of our adults on a standard formula with fiber, unless that was contraindicated. Also in the home setting, we found it beneficial to utilize a 1.2 or a 1.5 calorie per milliliter formula in order to reduce volume requirements for patients. And typically we did not start patients on a Blenderized formula unless they had documented food allergies. However, we did transition patients to Blenderized tube feeding if we found that they failed on standard or other specialty products. In my practice, we primarily had diagnoses of cerebral palsy, ALS, head and neck and GI cancers, including gastroenterological and dysphagia. We also had a significant pediatric population with diagnoses of cerebral palsy, feeding difficulties, and dysphagia. For my case study, we'll be focusing on a 28-year-old patient with cerebral palsy. Other diagnoses included a seizure disorder, aphasia, non-ambulatory status, dysphagia, history of a fundoplication, and a feeding gastrostomy. The patient's feeding plan was complete NPO with G-tube feedings. Throughout the time that I followed the patient, his weight did remain in a normal category. In the home setting, it's very common to have limited lab data, but the data we did have remained unremarkable. This patient's tube feeding journey began as a very young child when he was started on tube feeding. When he came to me, he was on a standard 1.2 calorie per milliliter adult formula with fiber. However, over time, we were receiving increased caregiver complaints of the patient being gaggy and crying, which they perceived. Throughout the process of finding a new formula, the patient's weight did remain stable within a 10-pound range. It's important to note the patient was on bowel medications and a protocol to promote regular bowel medications. Over time, the patient was trialed on multiple formulas, including a fiber-free formula, an isotonic formula, a calorically dense formula, and a peptide-based formula. Throughout this process, we saw minimal improvement in his symptoms. The decision was made to transition to a commercially blenderized formula to see if we could improve some of the problems that he was having. We did this with a slow transition by replacing one feeding per day until we reached his ultimate goal. This eventually resulted in a decrease in the gagging and crying that was being reported. We also saw a decrease in the use of bowel medications. There was an improvement in caregiver satisfaction, with the caregiver looked happier and healthier, which was really great. And due to the decrease in symptoms, we also saw decreased health utilization, where the caregiver was making much fewer calls to both myself, the dietitian, and the physician. Do we have any questions, Amy?
Yes, thank you. I've got a couple of questions for you. Thank you so much for that presentation. The first question that came in for you is there a challenge with the thickness of the formula going through the feeding tubes?
That's a great question. One of the important things when we're talking about making sure that the formula flows through the feeding tubes well is going to be the French size of the tube. So the recommendation is that the tube be a 14 French or larger. Some of the products will flow through a 12 French tube, but it's very product specific. And then occasionally some of these products will need to be thinned or flow through a little bit more easily.
Great, thank you. And I do have one more question for you. The use of blenderized products seems to be higher in home care. What are some practical applications for acute care, and what are the overall challenges and changes in processes that you'd need to consider for an acute care application?
Yes, that's something I'm very familiar with. In our hospitals here, we actually have closed systems. In our home settings with Blenderized tube feeding, we obviously have to use an open system. So that's one of the first things that acute care needs to be aware of, are their policies and procedures around administration methods and the ability to utilize a syringe feeding administration as opposed to a pump, perhaps. And then also having a substitute product available for those families who do utilize a home blend. Our hospitals do not allow a blend to be brought into the hospital. So we need to actually have a commercially available product available for them that can be used as a substitute for what they normally use at home. So having policies and procedures around that is also very important.
Wonderful, thank you very much. I think we can move on to our final speaker.
Hello, everyone. I am Miriam Shambayati. I am a pediatric gastroenterologist in Oklahoma City at Integris Baptist Medical Center. I completed my medical degree at the University of North Texas. I then went on to my pediatric residency at University of Texas at Houston, where I covered Children's Memorial Hermann Hospital, as well as MD Anderson and LBJ County Hospital. I then moved to the University of Oklahoma to complete my pediatric gastroenterology fellowship at the University of Oklahoma, and I joined a private group in Oklahoma City with the Integris Baptist Medical Center. So we are a community hospital located in the 25th largest city in the United States. And prior to opening up, we basically just had the university as the only GI group in the state. And so this has greatly increased the need for patients in the state. We do cover an inpatient floor, a neonatal intensive care unit, a pediatric intensive care unit, and I also manage outpatient tube feeding. I do not have a dietitian in the clinic, and so I often serve in that role for managing the tube feeds. One thing that's very important to me is to have an individualized process when choosing a tube feeding formula, and this is going to be based on whether the patient has underlying GI pathology versus a normal GI tract. So a patient who has short gut syndrome, who has disaccharidase deficiencies, has celiac disease, Crohn's disease, these patients are going to have special needs when it comes to formula choice versus the patient who is tube fed because of neurologic status and other factors such as trauma that are unrelated to their GI tract. So I do work very closely with families when deciding on a food-based tube feeding formula. A lot of this is going to be driven by our families and their needs and their goals for their child. There are different types of formulas that are used. One is traditionally blenderized. These typically come in pouches and tend to be thicker. There's also liquefied, which usually come in cartons. And these can typically go through a 12 French tube, so it's very useful in those situations, as well as for patients who need to be on continuous feeds, particularly those who are fed with a GJ tube, where they're being fed past their stomach into their jejunum, and as well as looking at peptide-based real food tube feeding. So this is where you take a intact protein and you start off with the actual food, and then it is broken down into, the proteins are broken down into peptides, and these often have a lower osmolality, which is important for tolerance, and it also can be very beneficial for patients who have underlying GI pathology. Another group of things to consider is whether the tube feeding is plant-based or if it contains meat in it. And so there are some forms that contain chicken or beef. You may see those. And then there are vegetarian or plant-based tube feeding regimens. So what's nice about having a mix of plant-based foods as well as meat-containing food or solely plant-based does provide the patient with some choices and the family with choices. Just like how in the real world we don't necessarily have meat at every meal, you can have some combination of things, and it can be a lot easier on the patients and improve tolerance. So I would say that I would agree with Tiffany that one of the most common challenges of hospital-based patients is tube feeding administration, bolus versus pump-assisted feeds. Bolus feeding is traditionally done with a syringe. I do often have to teach that to my families in the clinic because oftentimes in the hospital, when you have a nurse who's managing multiple patients, it's certainly easier to set a pump and forget it and move on. There is really a nice intimacy between mother and child when you're able to do these bolus feeds. I use the analogy to them that it's just like when you're feeding the baby, feeding a young child with a spoon. You can see when the child is full, you can see when they're not done chewing, all that whole process. And it's the same here. When you're pushing that plunger and giving that bolus feed, you can see the child's reaction. You can see if it's a little bit too much and you can slow down. So it really does create that intimacy and connection with their child that they do very much appreciate, and also gives them less time connected to things and a lot more freedom in their life. But some patients do really appreciate pump-assisted feeds, and of course, if they are fed past their stomach, they will require continuous feeds. So as far as the two settings, indications that we have for patients on tube feedings, in the acute care setting, such as in our ICU, definitely are intubated patients. Oftentimes, as soon as you're intubated, you have a tube placed, and it will require feeding that way. It's very easy for a patient to become malnourished in an ICU setting. at first you start off, you admit them, they're maybe just on IV fluids, shift change happens, you have new staff coming on each day, and sometimes people can forget that how important it is. And before you know it, a week has gone by and a patient's been on IV fluids, and then they start getting into a catabolic state. So it is important to think about tube feeding from day one, a way to provide nutrition from day one. So for patients who are status post oral pharyngeal surgery, we have a very strong ENT program here. We have a lot of patients with cleft palate or Pierre-Robin syndrome, other conditions where they're undergoing oropharyngeal surgery, and they have their surgery and then they can't eat for the next week or so. This is a situation where I say if you're able to get a tube in as early as possible to get their good nutrition, they definitely will need that for wound healing and in order to recover appropriately. Patients who are status post-trauma in the ICU setting and are unable to eat, as well as many patients who are acute failure to thrive. They are seen in their pediatrician's office and are off the growth curve and acutely admitted directly to our hospital. We typically will start off with NG tube feeds. So as far as in the clinic or home care setting, as far as why would I start a patient on tube feeding in the outpatient setting, aspiration is one big one. So we often have patients who come in and they're told, we're having a lot of coughing or choking, gagging when we eat. I then get a dysphagogram or a modified barium swallow, and it demonstrates aspiration. That would then indicate that patient would likely benefit from tube feeding. Oral aversion is a big one, especially in our NICU graduates. So these babies who were born early, they spent a lot of time being tube fed, and it's very difficult to get them to complete all of their meals orally, and that's where you would benefit from tube feeding while they continue to work with a speech therapist or feeding therapist to improve their oral intake. Malnutrition is a big one. We do have kids who are failure to thrive or have malnutrition, and they do benefit from tube feeding because they are unable to maintain their own caloric intake. Other conditions, so we can use tube feeding to treat diseases, GI conditions. One is called eosinophilic esophagitis. This is where you have white blood cells that typically are in charge of allergy, and they are inside the esophagus and lead to inflammation. In these patients, one way to treat that is with amino acid-based formula, and that can be given through an NG tube if the patient is not able to maintain their calories on their own. Another is total enteral nutrition therapy for Crohn's disease. This is actually the standard of care in Europe, that every patient pediatric patient who's newly diagnosed with Crohn's disease, they place an NG tube and they are on total nutrition therapy, total enteral nutrition therapy for 8 weeks. In the United States, it's still more common to use steroids. However, we do see more and more patients, families who are interested in dietary management, and this is one way that you can do that. So today's case, this is an 11-month-old boy with GJ dependence at his first visit. He is now 2 years old, and I'm happy to share his story with you. He was actually born with 17q12 microduplication syndrome, and this is caused by an extra piece of chromosome 17 that is present from the moment of conception. Neurodevelopmentally, these children can often have some delay, including speech delay, motor delay, behavioral concerns, and can present with autism spectrum disorder as well. There are some seizures can be seen in 3/4 of patients with this. They often have microcephaly and hypotonia, so small head size and low muscular tone. And the low tone is often one reason why these patients have trouble with oral intake. This patient also had truncus arteriosus, which is a congenital heart defect where there's a connection between the aorta and the pulmonary artery. And so there's only one large artery that's leading out of the heart. And so in these patients, sometimes volume can be an issue. We do have to, and then when they are preparing for any kind of corrective surgery situation, our cardiologist colleagues do want these patients to have good nutrition so they can recover from their surgery, have good wound healing, and less complications. He also has pulmonary hypertension, and he was dependent on a trach as well. And so he went from birth, he was in the NICU, and from there he was discharged to the Children's Center, which is an outpatient pediatric rehab facility. And at that point, he was then discharged at 11 months of age. A lot of patients who have trachs and G-tubes placed in the NICU often do go to a rehab facility in order for the parents to learn how to use the trach, be comfortable with using the trach and the G-tube, and in order to help get the patient onto stable respiratory and feeding regimen so that they can be stable for home and with no concerns, particularly if they live in rural areas like this patient does. He lives in a rural part of Oklahoma where their medical facilities are not as readily available close. It's quite a bit of a drive to get to areas where you have help. So his tube feeding journey. Well, initially in the NICU, he was receiving NG tube feeds, but he was noted to have emesis with them. So he was not tolerating nasogastric tube feeds. And so it was so severe that the pediatric surgeon actually placed a primary gastrojejunostomy. Now, for many of you, you're used to seeing a G tube being placed, gastric tube being placed, and that then later this can be converted into a gastrojejunostomy or G tube. So a GJ tube. So a GJ tube is one hole into the stomach. However, the tube has two ports of entry. You can feed into the G, you can feed into the J. The J side is a longer tube, which then goes through the pylorus, or the bottom of the stomach, into the small intestine so that the food is emptied into the jejunum, or the middle of the small intestine. The benefit of that is that the patient will not reflux the material up, and so therefore if the patient were to reflux and then vomit and aspirate, that would be dangerous. All of the food can go past that into the stomach, so you don't have anything coming up, so you shouldn't be vomiting formula. In this case, this was placed primarily. At first visit with me, when he was 11 months old and finally home, he was on a hypoallergenic amino acid-based powdered infant formula with continuous feeding via the GJ tube. Then at 12 months of age, I then changed him to the same formula, but the pediatric version. So most formulas, I essentially kept him on the same formula, and typically when they turn 1 year of age, we switch them to the toddler form. At 16 months of age, his mother expressed to me that she was interested in working towards G-tube feedings. So one difference between GJ feeds and G-tube feeds is that in G-tube feeds, you're able to give bolus feeding. With bolus feeding, the patient is not tied down. They're not having to be fed all day long and all night long, 24 hours a day. In this way, they're able to have more freedom, and they can also be fed more physiologically, chunks throughout the day, which definitely helps with motility. And so I started off with working him towards G-tube feeds. And as we started off with giving meds through the G-tube and then the bolus feeds. At 18 months, so 2 months later, he was tolerating bolus G-tube feeds and was doing all of his feeds through the G port of his GJ. So in the clinic, I removed his GJ tube and I replaced it with a regular G tube. And during that appointment, I also gave him a bolus feeding of a peptide-based, plant-based pediatric tube feeding formula with real food ingredients. So this way, I showed mom how to deliver a bolus feed using a syringe and how to deliver it with real food. These are liquefied, and so you don't have to worry about it being too thick for the child. And they typically are very well tolerated in our population. And since he tolerated this well, he began bolus feedings of this at home. And you can see on the chart how much he grew from 18 months to 2 years, very significant difference. And at 2 years of age, mom was very pleased, and she felt that she was ready to shift to blenderized feedings. She liked the idea of not having it broken down at all, and that really when you look at the food, it looks just like if you were to put it in a blender yourself. So he is now on a combination of commercially blenderized pediatric tube feeding formula made with organic whole foods, and also on a peptide-based, plant-based pediatric tube feeding formula with real food ingredients. So the reason for that is that because of his tube size, he does have a 12 French tube in place in order to help basically, essentially, for lack of a better term, water down the Blenderized formula. We use that peptide-based formula to help thin it out. Also, mom felt that when he goes to school, a lot of times the schools prefer to use a pump for the feeding, and that's this way she could have them use the pump, and then when he's at home with her, she can do the bolus feeds. Now, we recognize that while in the state of Oklahoma, Medicaid does cover having 2 formulas at once, and not all states do. And so if you were in a situation, or in a situation where insurance will only cover 1 formula type at a time for a patient, one thing that you can do in this situation would be to either dilate the gastric stoma so that you have a larger tube size, so go to a 14 French tube, or alternatively, you can water down the formula with actual water. Some people will even use things like coconut water in order to just get the patient some extra electrolytes with that change. But that is one way that you can thin it so that it can go through the tube more easily. All right, anyone have questions for me?
I'm just going to ask one question, then we're going to transition over to Francine Allen, and then we'll take, there have been several questions coming in, some of them that are appropriate for each of our speakers, which is great, and then we'll answer those at the end. So the one question that I have for you that came in right now is that, do you find issues in using Blenderized formulas in patients with food allergies?
I think that's a great question. Now, if a patient has eosinophilic disease, meaning on biopsy, you currently see that they have active eosinophils. In those patients, I would recommend amino acid-based formula until you can document the clearance of eosinophils. Typically after, it's pretty safe to say after 8 weeks, you should be able to biopsy and see that the eosinophils are gone. Now, if the patient has food allergies that are not eosinophils in the GI tract. So for example, anaphylactic food allergy, other kinds of food allergy, or found on skin prick testing, not anything to do with inside their GI tract. We have very good success with Blenderized formula, and part of that is that these are real ingredients and you can see what's actually in there. So for example, if a patient is allergic to eggs, you can use the one that doesn't have eggs. So very simple way to customize while still giving the family that satisfaction that we are in control in what my child is putting in their body. And it also makes a great base for working closely with a dietitian if you do want to modify for those food allergies. But we have very good success in these patients.
Wonderful, thank you so much. And now we'll move on to the last section of our presentation before we open it up to Q&A.
Thank you, Amy, and thank you very much to all the speakers. That was so interesting, and I love the case studies. Thank you. It really brings it to life and makes it so practical. Before we go on to Q&A, I just want to remind everybody or inform everybody about a tool that's available through Nestle Health Science. It's called the Blenderized Tube Feeding Recipe Builder. This tool is a database that's available on complete.com. And what you can do with this is develop nutritionally complete home Blenderized recipes for children 1 to 13 years that are on a home Blenderized tube feeding formula. You're able to select certain preferences or certain things that the child cannot have, such as nuts or dairy, etc. It generates a recipe, it saves it, it generates a shopping list, and you're able to send the recipe to other people if you want to, perhaps a daycare, a relative, anyone else who might be taking care of the child. This tool was developed in collaboration with the Children's Hospital of Philadelphia, and in particular, Robin Cook, who's a pediatric surgery and trauma dietitian at Children's. She has a lot of patients on home Blenderized tube feedings, and it was very difficult to develop recipes that met the needs of each of these unique children and their unique needs. She had a ton of different spreadsheets available, and we were able to work with her to put these into a web-based tool. And again, it is a free tool on complete.com. And the way it works, it's very simple. Go onto the tool, create a profile for the child, add in the child's age, the calories that they need, any fluid restrictions if applicable, and then you can deselect any foods that they might be allergic to or you prefer that they not have. The next group will show you how to develop the tube feeding formula. And then at the end, it'll generate the recipe as well as nutrient information. As I said, a shopping list and a way to store it in your recipe box. So once you create the profile and you indicate the child's age and the number of calories they need and the volume restriction, if any, you move through 8 different screens, and these are the 8 food groups: nutrient-rich base, protein-rich foods, vitamin A fruits and vegetables, vitamin C fruits and vegetables, additional fruits and vegetables, potassium-rich foods, grains, and healthy fats. And as you move through each of these 8 categories, the tool won't let you move to the next group until you select enough of the foods from one category to meet their specific nutrient requirements. So for the nutrient-rich base, it would be the protein requirements, etc. For the fruits and vegetables with vitamin A, you won't be able to go on to the next slide until you choose enough servings of fruits and vegetables that will provide enough vitamin A. And the number of servings are right there in the in each of these categories, so you know exactly what you're aiming for. And you can choose all of one, all carrots if you want to, or you can divide the servings up between carrots and sweet potatoes, whatever you happen, whatever the parent happens to have on hand. So I definitely urge everybody to try it out. It's on complete.com. You can register, play with it, see if you like it, and certainly hopefully recommend it to some of your parents who are creating their own Blenderized tube feeding formulas. So let's go to the next slide and move on to general questions for the panel.
So happily, we have some really good questions that have been typed into the questions pane while you've all been speaking. And I have, right now, I have one that I think is appropriate for each of the speakers. And the first question is for Dr. Shambayati. And the question is, I've been seeing patients with more abdominal distension and gas upon switching to a Blenderized tube feeding. Have you seen this? And if so, what do you do to alleviate it?
I would say that that's likely because of the increased osmolality that you have with Blenderized, that you can have with full intact protein Blenderized meals. And so what you want to look at when you talk about osmolality, really you're saying the higher it is, the thicker it is. The lower it is, the closer you are to water. And so that's really going to help with gastric emptying. Bloating happens when you're having, the stomach is slower to empty, or you have an influx of fluid coming into basically an osmotic effect happening, and you have an influx of fluid coming in the intestine, and you get that bloating effect that happens. So in cases like that, I do feel that a peptide-based whole food formula is going to be more beneficial because you do have a lower osmolality. Oftentimes our peptide-based forms do also come in 1.5 calorie ml, which is great for increased concentration. And so you have lower volume. That's another great way to get around that because there's less volume for the patient. And because the peptide-based formulas are thinner and can be given over a pump, for some patients who do need to have things run more slowly, you do get that benefit as well. So I do find that a lot of patients who don't tolerate the full Blenderized pouch-based protein or formula do benefit from the peptide-based.
Great, thank you so much for that. The next question will be directed to Gerard. And the question is, do you have issues with kids with low muscle tone handling the larger stools usually associated with Blenderized tube feeding?
I'm not sure I would relate that to just a change in formula. A lot of the patients that may have had that problem probably had it before the change and may have already been on a bowel regimen. So a lot of times when you make the formula change, if the symptom doesn't become more improved, then you can probably continue the same bowel regimen that they were on, or you can make some other food adjustments. I can add more fiber to the regimen. I use flaxseed sometimes with the regimen. Maybe if you're diluting out the formula to make it thinner, to go through the tube, you may add a little additional water if need be to help those patients. But I would assume those patients probably had that issue prior to the change in the formula, and they may need the same regimen to help them go to the restroom even afterwards.
Great, thank you very much. And please, all the speakers, I'm kind of directing these questions to different speakers, but if you have a different answer or you want to expound on what Gerard said, please do. And if any of you have anything to add to that. No?
I would
Okay.
say one thing you might want to think about is adding free water as well, because these are thicker formulas. So sometimes addition of free water can help in those situations. I also have patients have success with things like aloe vera juice through the tube that to also help with that. So while I know we often think of formula only, I think part of our talk today is just to not be afraid of using real food, and so that includes things like fruit juices. I do have some patients who benefit from prune juice through the tube as well to help with that. So there's just some other things that you can sometimes add in, but I would agree with Gerard that when it comes to that you don't want to forget a good bowel regimen and the patients who need it.
Great, thank you very much. The next question I'll direct to Tiffany. How long do you trial patients on formulas before trying another?
In my practice, we would typically give it a good 2 weeks just to make sure that they've had they've been on the formula and we can really see if that's going to work for them. And it gives it we're not just seeing, are we having good gastric tolerance, but also, are we having good bowel movements and all of those great things that if we do it for just a couple of days, we may not necessarily see.
Great. Dr. Shambayati, Gerard, do you have a different answer or something to expand on that?
Well, mine's both, I think I pretty much agree with her. A lot of times it's guided by the parents and what the intolerance may be. I do try to encourage families to continue trying formulas and not to change them too rapidly.
Yeah, I would agree with that. I typically try to provide samples for at least a week to get some feedback. Of course, it can be hard to change with our DMEs. The formulas patients are on all the time, so this is where being able to give samples is probably one of the best ways to trial. And I am a big fan of in-office trials, just like we did with this patient, where you're able to troubleshoot. Sometimes the families don't, it's almost operator error. Sometimes there's different factors as to why they might not be tolerating. And so if you have the opportunity, I know it can be time intensive, but if you have the opportunity to watch them give a feed in the office, that is one way to maybe troubleshoot some things.
Great, wonderful. And actually, Dr. Shambayati, now that I have you, one question is, are there contraindications to using food-based formulas in critically ill children?
You want to look at your underlying cause of why we're critically ill. So for example, if you have a new diagnosis Crohn's disease patient, you're not going to want to use blenderized food. You're going to want to use, total enteral nutrition therapy is where you use one protein source. You don't want multiple proteins for that patient. If you have a patient in a pseudo-obstructive crisis, for example, so they have severe motility issues, you do not want a very high osmolality that this kind of formula would provide. You're going to want to go with peptide based, but you're going to want not from blenderized food. You're going to want a traditional 1.0 unflavored. You don't want any additional flavors. You want that osmolality as low as possible, and so that those can pass in those patients. So those are definitely things to look at. If you have situations where patients need gut rest, obviously you're not going to want to feed in that case. So I would say that yes, those are important scenarios that you want to look at. And I think sometimes in our rush to discharge patients, sometimes things escalated a little too quickly, and then they fail, and you wind up being an extra 3 days in the hospital because you pushed too hard at certain points. So I do think that that's important to recognize, that you do want the patient to be stable. But that said, I think sometimes if they're ill because of things that are not GI related, because of neurologic or other conditions, this is a great opportunity to use real food.
Great, thank you so much for that comprehensive answer.
So thank you again to everybody on today's panel. This was excellent. I really enjoyed it, and I hope everyone else did as well. Very great information shared. Thank you. So on behalf of Nestle Nutrition Institute, we hope you found this information helpful, and please enjoy the rest of your day. Thank you.